It is now 3:25 p.m. and we will now reconvene the meeting to begin public comments. I'd like to welcome and thank our public comment speakers for addressing the committee today. All the speakers today submitted a request in advance of the meeting, and the final list of public commenters was determined via a lottery. For our speakers today, we do have a limited public comment period, and in order to make it through all of the listed speakers, it is extremely important each speaker limits his or her remarks to 3 minutes. We will be displaying a timer on the screen so you know how much time you have left. And I want to thank our speakers again, and we look forward to your comments. So first, our first public commenter today is Mr. Steve Kirsch. Mr. Kirsch.
Hi, my name is Steve Kirsch. I'm Executive Director of the COVID-19 Early Treatment Fund. I have no conflicts. Today, I want to talk about the two elephants in the room that the ACIP committee members all refuse to acknowledge. The first is the correct values of the VAERS underreporting factor, and the second one is the missing of dozens of serious adverse events, including death. The recognition of either of these elephants should cause the committee members to demand an immediate halt to the COVID vaccination program. Our first elephant in the room is a very serious error committed by CDC staff member who is the VAERS expert. The ACIP committee has relied on Dr. for interpretation of the VAERS data, but he has misled the committee on critically important issue, the underreporting factor for VAERS this year, otherwise known as the URF. He has led you to believe
can you please pause the timer? Thank you for your comment. You know, our committee does appreciate diverse viewpoints that are respectful in nature and that are not personally directed at individuals. I will ask that you not name individuals. Otherwise, I will need to cut your time short and ask that we move on to the next public comment speaker. But we will go ahead and resume the timer, Mr. Kirsch.
Okay, the committee has been led to believe that VAERS is 100% reported. That is preposterous. The VAERS URF is at least 41 for serious adverse events this year. It was calculated using methodology outlined in a paper published by 5 CDC authors published last year. I used the anaphylaxis data from the Blumenthal study, a study done at Mass General Brigham, published in March 8 in JAMA. Those rates, the rates determined in that study largely agree with those found in the Hashimoto study published on June 14th in the Journal of Travel Medicine. If you cannot challenge the methodology or the data, the precautionary principle demands that you accept the result, which is the URF is 41. Now, this has profound implications. The myocarditis incidence rate is now 1 in 317 fully vaccinated 16-year-old boys for the Pfizer vaccine based on slides presented at the August 30 ACIP meeting. But much more important is the death count. There are 74 deaths reported in VAERS as of today. Let's remove the total of all deaths reported in an average year, considering all those background deaths. So minus 200. 74 times 41 is 306,000 excess deaths this year. We should have stopped the vaccines at 50 deaths. We even used 7 independent methods to validate our estimate is correct. None of those other methods use VAERS. I even offer a $1 million prize to anyone who can find a material error in either the data or the methodology. Nobody's claimed that prize. Contrary to CDC's claims, we can show causality of all of these deaths because all the Bradford-Hill criteria are satisfied. So if the vaccines didn't cause those excess deaths, then what did? The committee must answer that question, or I believe they should resign. There is a second elephant in the room, which is the missing safety signals. How can you miss 300,000 dead Americans as safety signal? How can you possibly miss pulmonary embolism? It's elevated by over 800 times this year versus previous years. There are dozens more examples like these. The committee should either call for an immediate halt to the vaccination program or they should resign. Thank you.
Thank you for your comment. And we'll move on to the second public comment speaker, Dr. Robert Edmonds.
Dear committee, my name is Robert Edmonds. I have no financial conflict of interest to disclose. While my remarks are more tuned to tomorrow's agenda, today I will speak about tinnitus and the Johnson & Johnson vaccine. COVID-19 vaccines, including Johnson & Johnson's vaccine, have saved many lives. Identification, though, of low-frequency adverse events connected to vaccination are important, not to discourage vaccination, but to encourage patient education to seek timely care, and for provider education to apply the appropriate treatment should these low-frequency events occur. Peer-reviewed case studies of tinnitus following vaccination potentially suggest a small window of time for treatment of tinnitus after onset utilizing corticosteroids. After this limited window, though, management is often the only remaining option available. Last week, Johnson & Johnson presented data That indicates a combined imbalance from all phase 3 trials of 24 versus 9 for tinnitus without information about the distribution of preconditions in both the vaccine and placebo group. We can only surmise the chance of a coincidental signal is 1 in 143 for this scenario, and if the case and from phase 1 is included, 1 in 156 for consideration of all phases of development. Note, last week's update increased confidence in tinnitus as a real signal. Additionally, the 95% confidence lower bound to the signal, already above 0, increased away from 0 with this update as well. Note, the confidence intervals and confidence estimates have not been provided for these adverse events in any documentation. The Food and Drug Administration at this time, unlike the European Medicines Agency, has not recognized tinnitus as a related low-frequency event. Therefore, I urge an investigation beyond passive monitoring. Investigation of this nature would probably first indicate what tinnitus background to compare to, like whether comparisons should be conducted against what would include an assumed non-bothersome tinnitus background, or only a smaller, more severe, extremely bothersome tinnitus background. Without an investigation of this nature, it would be difficult to detect a tens of % rise in an assumed large background without unique consideration of severity. Additionally, more careful examination may or may not identify a unique nature to the cases, exclude or include other potential causes, and could identify unique cases hard to explain without a causal relationship. I'd be happy to expand upon any of these points after these remarks. In closing, I return to the trial data. I will repeat, combined trial data presently indicates a 1 in 156 chance of there being a coincidental signal. If you agree these events are unlikely to be coincidental, as the trial data suggests, I urge further investigations with federal and private partners to further investigate this matter and communicate those results back to the Food and Drug Administration, and if real, meaningfully communicate this to patients and providers as well. Thank you for your time.
Thank you for your comment. We will move on to Aaron Costello.
Hello, everyone. I hope you're all having a fine afternoon. I have two purposes for my statement being made here today. First and foremost, I want to thank every committee member for your work and your efforts given to helping every member of the public avoid unnecessary and sometimes detrimental sickness and disease. I especially want to thank you for agreeing to be a part of this committee over the past few years, given the rise in misinformation, which has then caused some people to misplace their anger that they feel and place it on you and other members of the medical and scientific community. I can imagine how unnerving that can be at times. Myself and other parents, and even those of us without kids, have devoted our free time to hopefully reversing some of this anger and ignorance. I am even hopeful on some days, though not often enough. My last purpose here for speaking today is to express my hope that the recommended age for the shingles vaccine be lowered from 50 years of age to 45 years of age. So I know myself, I would be very much relieved, but mostly I just want to say thank you very much for all of your time and your efforts dedicated to this cause.
Thank you for your comment. Our next public speaker is Dr. Yu Lin.
Am I unmuted? Okay, good. Hi, this is Yu Lin from the University of North Carolina at Chapel Hill. Our group have been estimating the durability of protection for the COVID vaccine from both phase 3 trials and the surveillance data. So today I'd like to share some of our results. So first of all, we analyzed the first 3 trial data that published in New England Journal of Medicine for the Pfizer and the Moderna trial, and we found that the vaccine efficacy in reducing the risk of symptomatic COVID-19 is about 75% at 6 months after dose 2 for the Pfizer vaccine, and for the Moderna vaccine is at about 90%. 6 months after dose 2. So this suggests that there's not as much need to give booster to the Moderna vaccine recipients as compared to the Pfizer vaccine recipients. Our group have also been analyzing the surveillance data from the state of North Carolina, and I want to mention some of these results. First of all, we estimate the vaccine efficacy in reducing the risk of COVID-19 over a 9-month period, and we find that both mRNA vaccines are highly effective in reducing the risk of hospitalization and death with the vaccine effectiveness in the low 90s percent, even after 7 or 8 months. And the Moderna vaccine is more durable than the Pfizer vaccine in reducing the risk of COVID-19, just like in the case of the phase 3 trial. And the durability of protection are similar across demographic group. And also waning patterns are similar across different for people who are vaccinated at a different time, suggesting that waning vaccine efficacy is likely due to the declining immunity rather than the emergence of a new variant. And also, we find that the effectiveness of the Johnson vaccine dropped after 1 month, which suggests that it will be worthwhile to investigate the effectiveness of Johnson vaccine as the 2-dose regimen, given approximately 1 month apart. And that's the end of my comments.
Thank you very much for your comment. Next, we'll move on to Ms. Patricia Barber.
Good afternoon. I am Patricia Barber, a retired banker and a nonprofit executive. Thank you for this opportunity to speak and for the diligent work this committee and staff have done over this difficult and lengthy period of crisis in the health of our country. As a senior, I am particularly aware of the value that vaccines play in keeping me in good health. From personal experience and from health education, I know that pneumonia is one of the health threats facing older adults and that it causes thousands of hospitalizations and deaths each year. Any increase in the effectiveness of preventing this dangerous infection is an important step in the right direction for all of us. One of the things that I and so many others have learned more about through the COVID pandemic has been the degree to which our body changes and becomes more susceptible to illness as we age. We are now so much more aware that our immune systems decline significantly as we age. And we know that the degree and the rapidity with which that occurs seems to vary for a number of reasons, but that the decline is inevitable. I hope the committee will factor the full impact of this into its deliberations. We know that there are many predictable biological events which serve as hallmarks for the body reaching various stages of seniority, from graying hair to wrinkles to slow metabolism. We also know that these occurrences don't all happen at the same time in each one of us. Thus, it is important to recognize that aging begins and advances at different times and at different paces. We need to keep this in mind so that the changes in our immune system, which may not be apparent to the eye, can and will be addressed appropriately. Protection from pneumonia is a prime example. While we know that the oldest among us are the most at risk, so-called younger cohorts of seniors, those in their 50s and 60s, also are experiencing, in varying ways and measures, changes that mark the advance of age. The old adage, an ounce of prevention is worth a pound of cure, comes to mind. Restated for this situation, a broad definition of seniority will protect and save a multitude of seniors. Thank you.
Thank you. We'll move on to Dr. L.J. Tan.
Good afternoon, members of the ACIP. I am L.J. Tan, Chief Policy and Partnerships Officer for the Immunization Action Coalition, or immunize.org, and also co-chair for the National Adult and Influenza Immunization Summit. I'm also honored to have served as a voting member of the NVAC, the National Vaccine Advisory Committee, and as a liaison member of the ACIP for 12 years. Just a few comments regarding the vote of the committee to not amend the age-based pneumococcal policy statement down to 50 years of age. While harmonizing an age-based recommendation is commendable, it shouldn't have been done at the expense of improved health outcomes for a large population of vulnerable persons. Indeed, this seems unreasonable when the alternative was another age-based, cost-effective, even cost-saving recommendation. I'm concerned that the current policy statement appears to show more considerations for the vaccine options than the benefits to vaccine recipients. Why? As we all know, there remains a large burden of preventable pneumococcal disease today, and we know that from the implementation of other adult immunization programs, that with an age-based recommendation down to 50 years of age, we will capture a significant number of persons who may go on to become diagnosed with high-risk conditions. Indeed, our current pneumococcal high-risk recommendation for adults 19 to 64 years of age has been in place for many years, and we are sitting on low coverage rates hovering at 23.6%. There is no reason to think that simply changing the vaccine options will change these low numbers. We have tried with various vaccines, and the evidence is clear. Risk-based recommendations in adults are poorly implemented, and the data has shown that indeed age-based recommendations in adults do work. An age-based 50 to 64-year-old recommendation would have provided immediate benefit to a high-risk population rather than keeping them at risk while waiting for some future program to reach effectiveness. We would also have captured a significant number of vulnerable persons of racial and ethnic minority and also of lower socioeconomic status who may otherwise miss vaccination with a risk-based recommendation. This is an issue of equity. And finally, waning immunity does not seem a good reason to not seize the opportunity to reduce a lot of burden of disease today. It seems inappropriate to not implement a cost-effective solution that will save more lives, improve equity, based on an assumption that immunity might wane 15 to 20 years in the future, regardless of boosters. That said, with the policy statement now under consideration, immunization advocates stand ready to work with you to address the challenge of implementing a risk-based pneumococcal recommendation and indeed all other adult risk-based recommendations. On the broader issue of adult immunizations, the negative impact of COVID-19 on immunization coverage rates in the U.S. has been well documented. We are aware coverage rates in the adults were very low pre-COVID, and we all know that when coverage rates are low, disparities are exacerbated. The pandemic devastated our already low adult immunization coverage rates, and we were delighted that Dr. Koh mentioned a call to action that was developed by the National Adult and Influenza Immunization Summit. I urge all of us to consider these standards for care going forward. I would like to thank this amazing committee for the incredible body of work that you all have done to protect the health of the country, and in particular over the past 2 years as we continue to engage in getting out of the pandemic and back to life. We stand ready to work to implement your important recommendations and protect the health of the public.
Your comment, your time has expired. We'll move on to Mrs. Jeanette Contreras.
Thank you, Dr. Lee. My name is Jeanette Contreras, and today I am representing the National Consumers League, which for over 120 years has championed the safety and efficacy of vaccines as life-saving medical interventions. We extend our gratitude to this committee for the opportunity to present public comment. Our founder, renowned social reformer Florence Kelley, supported vaccines as a key factor in mitigating a smallpox outbreak near the end of the 19th century. And her stalwart advocacy for immunizations has informed our bedrock principles for increased access to and vaccine confidence among consumers. In the U.S., nearly 50,000 people die each year from pneumonia, and Americans living with underlying health conditions are at a higher risk of acquiring the illness. Given the prediction of a more active flu and pneumonia season this year, the threat to older Americans and those living at greater risk of infection is especially high. Coupled with the ongoing threat of COVID-19, a rising number of Americans who recover from the coronavirus will find themselves susceptible to respiratory infections. We are pleased that the FDA has approved 2 new pneumococcal vaccines that offer broader protection than existing options. Consumers rely on the scientific expertise of the FDA and CDC to make recommendations based upon the best available evidence. We are encouraged that ACIP is considering recommending the pneumococcal vaccine for young adults with underlying health conditions and adults over age 50. Providing clear age-based recommendations can help to increase the rate of vaccine uptake. Providing risk-based recommendations for young adults with underlying conditions increases equitable access to immunizations. These recommendations would be particularly significant for vaccine uptake in communities of color who suffer disproportionately from chronic medical conditions at younger ages. As we work to reduce the risk of serious illness and death this winter, a vaccine to prevent against pneumococcal disease is more relevant than ever. Ensuring our most vulnerable Americans have access to these important preventative tools must be our priority. The National Consumers League will continue to instill vaccine confidence in consumers and look forward to swift recommendations by this committee on the use of these new and improved pneumonia vaccines. We appreciate your consideration of our views on this important public health topic. Thank you.
Thank you for your comment. Joanna Colburn is the next public speaker.
Good afternoon. I'm Joanna Colburn, Deputy Executive Director of the National Foundation for Infectious Diseases, or NFID. On behalf of NFID, thank you for the opportunity to address ACIP, which plays an important role in guiding U.S. immunization policy and protecting public health. COVID, flu, and pneumococcal disease are vaccine-preventable diseases that together cause millions of illnesses and thousands of hospitalizations and deaths among vulnerable populations, which include older adults and those with chronic health conditions. Although there are safe and effective vaccines available to prevent these diseases, research shows a lack of awareness on the part of many individuals who are at higher risk for serious complications. Given that fewer than half of U.S. adults typically receive an annual flu vaccine, NFID commissioned a survey in August 2021 to better understand beliefs about flu and pneumococcal disease, as well as attitudes and practices around vaccination during the COVID-19 pandemic. The survey found that 44% of U.S. adults are unsure or do not plan to get vaccinated against flu this season. Of further concern, the survey found that nearly 1 in 4 who are at higher risk for flu-related complications said they were not planning to get vaccinated. Although last flu season saw historically low flu activity, we could see flu surge in the U.S. this season with relaxed COVID-19 mitigation strategies, increased travel, and the reopening of schools and businesses. Now more than ever, it is essential that everyone aged 6 months and older receive an annual flu vaccine. Even in cases when flu vaccination does not completely prevent infection, it can reduce the duration and severity of illness and can help prevent serious complications, including hospitalization and death. The survey also revealed an alarming lack of knowledge about pneumococcal disease. Among adults who are at higher risk for the disease, 51% are not familiar with pneumococcal disease, and only about a third report that they have been advised to get vaccinated. Healthcare professionals play a critical role in protecting their patients from vaccine-preventable diseases. Both healthcare professionals and the public must understand immunization recommendations for all vaccine-preventable diseases. This fall, millions of people will be rolling up their sleeves for additional doses of COVID-19 vaccines. Although COVID and flu vaccines can be given at the same time, there continues to be confusion as well as practical concerns about implementation. Clear, consistent guidance from CDC is essential to eliminate confusion. At the recent NFID News Conference to kick off flu season, CDC Director Rochelle Walensky urged everyone to get vaccinated against influenza each year. NFID stands ready and willing to continue working with CDC throughout flu season to educate the public and healthcare professionals about recommended vaccines. Thank you for your time and attention and hard work.
Thank you for your comment. Our last public speaker for today is Ms. Meredith Whitmire.
Thank you, and thank you for the opportunity to present to you. My name is Meredith Whitmire, representing the National Association of Nutrition and Aging Services Programs. We commend you for the extraordinary work you continue to do throughout the COVID-19 pandemic, work that certainly has saved lives. I have one simple request today. Please immediately reconsider your decision not to vote on extending coverage of newly approved and updated pneumococcal vaccines to all those aged 50 and older. As an organization which has been advocating on behalf of pneumococcal vaccines for older adults since 2014, we do appreciate that you are considering coverage for all those 65 and older. However, after reviewing the evidence from the pneumococcal working group, it seems evident that these vaccines would benefit a broader aged community, particularly as we begin this flu and pneumonia season that is expected to be a very active one. Further, many young or old with chronic conditions are susceptible to pneumococcal disease, as discussed by the working group. These conditions disproportionately are found in populations of color and often go undiagnosed, meaning that these adults would be missed via the risk-based recommendations. Additionally, as was discussed earlier, the working group highlighted that one of the approved vaccines only requires one shot, another potential way to increase equity among vaccine recipients. As we stated in oral testimony in September, another compelling reason to recommend approval now is CDC's own guidance that pneumonia vaccines can be administered along with COVID-19 vaccines. As more Americans, especially older Americans and those with chronic conditions, either get their first or second doses of COVID-19 vaccines or their boosters, it would be such a convenience to have both done on the same visit. Just as you have moved swiftly and decisively at different junctures on COVID-19 vaccine recommendations,
We believe the same urgency is needed with respect to these pneumococcal vaccines for all adults 50 and older. Older adults have been disproportionately impacted by the pandemic, and so have the younger old with chronic conditions. We should avert the same situation with pneumonia. Finally, we also commit to doing all necessary education to inform the older adults we work with and others who would be eligible about the need for and availability of these new vaccines. Thank you.
Thank you very much for your comment. And with that, our public comment session has now ended. We will take a 5-minute break and return for the voting session. So everyone can be back at 55 after the hour. Thank you very much.